Assalamu alaikum. Thank you for the kind introduction. I'd like to thank the Congress chairs and the scientific committee chairs, namely Dr. Faqih, Dr. Shaheen, and Dr. Al-Otaibi for the kind invitation. It's always endearing to enjoy the warm hospitality in the Saudi Arabia. So in my first talk, I'm going to be talking about myelodysplastic syndromes classification, risk stratification, and response criteria. As you well know, myelodysplastic syndromes are a group of neoplastic stem cell diseases characterized by bone marrow failure, a tendency to progress to acute myeloid leukemia in almost 1/3 of the cases. However, majority of the patients unfortunately die from complications of the disease. And we know now that this is an interplay. It's a syndrome that also, there is a lot of interplay with comorbidities for the patients. So as we understand more the biology of the disease, we are resetting the platform of classification and risk stratification and response criteria, hopefully translating that to better treatment options for our patients. So as you know, the MDS classification has evolved over time from a very simple two classification of CMML and refractory anemia with excess blast to different iterations of the WHO classification. And finally, last year, we had a split. It's more like a political split, actually, between the WHO and the international classification consensus. So now we face two classifications for MDS. But in reality, the similarities are probably more than the differences between those two classifications. And I think the most important is, remembering first, in a classification, it's really a way to diagnose the disease and put patients into a homogeneous disease groups based on biology. It's not intended to be always a prognostic tool for those patients. The similarities between the two that now we recognize molecularly defined entities in MDS. So both classifications definitely recognize three genetically defined groups: SF3B1 MDS, deletion 5q, and TP53 mutation. Those groups have different biology, unique biology, that distinguish them from other groups. There are subtle differences between the two groups. For example, the SF3B1 MDS ICC requires a variant allele frequency more than 10%, absence of RUNX1 or TP53. The WHO does not require that. The TP53 mutation group is also a little bit more detailed in the ICC. So we have what we call the biallelic P53 abnormality if we have two mutations, a variant allele frequency more than 50%. But the ICC also recognizes a monoallelic P53 if the blasts are more than 10%. Now, we still obviously have morphologically defined entities. So we have MDS with low blasts. We have MDS with excess blast. They changed the name to increased blast rather than excess blast. The WHO introduced two categories: hypoplastic MDS when the blasts are less than 5%, and that's because it has therapeutic implication where immunosuppressive therapy can be used, and MDS with fibrosis because that has prognostic value. One of the major changes by the ICC is introduction of this, what we call MDS/AML. So if the myeloblasts are more than 10%, we call it now MDS-AML. That created a lot of discussion or controversies about that. In a way, it facilitates use of some of the treatments approved for AML for MDS patients, but also creates a dilemma in which response criteria to use, eligibility for clinical trials, and so forth. Now, we tried to provide some data-driven evidence for this classification. So we collaborated with the Italian group where we were able to put together 7,000 patients to try to look at those classifications and see if we can, come with a data-driven classification for MDS. So obviously, what we found that definitely MDS with SF3B1 is unique. Those are the patients that have the best outcome. They are around 12 to 13% of MDS patients, have almost 10-year survival and less than 5% chance to progress to acute myeloid leukemia. If you don't have molecular data, patients with MDS ring sideroblast, 80 or 90% of them will be actually SF3B1 mutant. How about if the patients had MDS ring sideroblast but the SF3B1 wild type? That's a very small group, 4%, but they actually don't have the same good outcome like patients with SF3B1. So if you have molecular data and there is no SF3B1 mutation, MDS with ring sideroblast behave like MDS low blasts. Deletion 5q is also unique. It's around 5% of the patients. It probably has the second best prognosis after SF3B1. With a survival in the range of 6 to 7 years. P53, unfortunately, is our worst enemy in this disease, whether it's MDS or AML, particularly a biallelic P53. In the group of monoallelic P53 were more than 10% blast. They also had worse outcome, partly driven by the P53, but mostly also driven by the increased blasts. Now, definitely when the myeloblasts are more than 5%, we should think of this as different disease. It's a different biology. Where do we put the line, whether it's 5 to 9, 10 to 19, is not clear. In our data set at Moffitt, there was no difference between 9% blast versus 10 to 19. In the Italian data, there was difference in the survival. The reason the ICC put the 10% cutoff is to have more firm line, because there is some variation. Like if we have a blast count of 6 or 7%, that could be really 4 to 7. So they use 10 because of arbitrary to be sure that the blasts are more than 5%. But we really don't know exact cutoff of the blast. But once the myeloblasts are more than 5%, that's different biology of the disease. So this is a way of thinking of how to diagnose and classify the MDS. I think we look at molecular markers first. If patients have biallelic P53, if the blasts are not increased, are they deletion 5q or SF3B1, and the rest is molecular classification. But this is my own version of how I think of classifying MDS. I think we should think of it in a conceptual way. So we have an indolent or chronic phase. So those patients have good outcome. That's the SF3B1, the deletion 5q, or the myeloblasts are not increased in absence of bad mutations. Then we have an accelerated phase MDS. Once the myeloblasts are more than 5%, if we have biallelic P53, or if we have MDS with fibrosis. And finally, we have AML that's MDS related, whether the patients had a prior history, there are certain cytogenetic abnormalities or gene defining for MDS. Now, similarly, the risk stratification had been evolving from the IPSS to the revised IPSS, and now introduction of the molecularly based international prognostic scoring system. So the IPSS-M was built based on the revised IPSS, so it still put weight on the clinical variables, such as the myeloblast percentage, the cytopenias, and the cytogenetic abnormalities. But it also integrates the molecular data. Actually, from the clinical variables, they excluded the neutropenia, because neutropenia in multivariable analysis was not correlated with outcome. So it retained everything in the IPSSR except of the neutropenia. And then they introduced data from 17 gene variables as main effect, and other 16 genes or 15 genes as second residual genes. And this is very easily calculated on a web-based calculator, where you can put the patients in 1 out of 6 categories with a relative risk to an average patient as shown here. So we have 3 categories now that we call lower risk, and 3 categories that we call higher risk. So what we learned through this is basically certain mutations are really associated with worse outcome, not surprisingly the TP53, the MLL tandem duplication, which is really not available in commercial labs at this point, was something we learned through this. And also a small subset of MDS patients will have the FLT3 mutation and have bad outcome. Also, we learned that also even good mutations like the SF3B1 are dependent on the context of the co-mutations. So patients that have SF3B1 with deletion 5q, although separately both are associated with favorable outcome, together that group don't have favorable outcome and probably less response to traditional therapies like lenalidomide or luspatercept. The co-occurrence of SF3B1 with certain mutations, namely RUNX1, is also associated with worse outcome. But when you apply the IPSS-M, you really restage almost half of the patients. And in 7%, the restaging is more than 1 stage. And now we can divide those patients into those 6 groups, as I mentioned, with a lifespan of 10.6 years in somebody that we call a very low risk, to less than a year probably in somebody who's high risk. But if you think of it all over, almost 42% of the patients are going to be considered a higher risk MDS. So we attempted to look at this in our data set. So we looked at almost 3,000 patients, and we saw figures that were superimposed basically on the original publication. So this is very reproducible. The outcomes of patients are same, and the same data in upstaging the patients were observed in our cohort. We then tried to look at subsets of MDS. So how does the IPSSM perform in therapy-related MDS? And it was very similar. The IPSSM is very predictive of outcome in therapy-related MDS. Similarly, in patients with hypoplastic MDS. And even for CMML, if you apply the IPSSM, it's predictive. It's probably as good as the CPSS model that's really specific for patients with CMML. We also collaborated with the group at Mayo Clinic looking at MDS MPN non-otherwise specified, and again the IPSSM was predictor of outcome. So for somebody who's busy in clinical practice and using models for every subtype of those, the IPSSM seems to be a valid and a useful tool for risk stratification across all subtypes of MDS. So the question, what to do with that? So there is no doubt that the IPSSM is a refinement of the IPSSR and allows you to predict the outcome for patients in a better way. But do we act based on that? This is the first attempt to look at that from the Italian group, and they were suggesting that for transplant, yes. So if we have staged a patient with the IPSSM, that we probably should be considering transplant for those patients. However, not necessarily to start treatment like hypomethylating agents, because the survival advantage for hypomethylating agents in MDS patients is mostly through restoration of effective hematopoiesis. Most of the time, what hypomethylating agents do is differentiate the clone. They don't eradicate the clone. So just upstaging patient doesn't mean that you have to start hypomethylating agents. But if the patients are in an age group that can be considered for transplant, then yes, based on the IPSSM, you should consider that. To further work on that, we actually again collaborated with the Italian group, and this is work that we're going to be presenting at ASH in details. The original training cohort from Italian group and the validation cohort from Moffitt. We looked at the maximum gain of survival based on using the IPSSM for risk stratification. And again, if you upstage patients and transplant them, that's where we observe the maximum gain. So if you are going to use the IPSSM versus the revised IPSS, you are going to change your decision on transplant in almost 45% of the patients. 13% you are going to delay the transplant actually because you downstage those patients. And in 32% of the patients, you are going to take them to transplant earlier because of application. So I think the IPSSM is ready to be used on decisions for transplant, but not necessarily to start a treatment if patients are not going to transplant. Similarly, I think for the response criteria, we revised those recently to reflect a little bit better understanding of the benefit of treatments for patients. So the complete response or complete remission rate or complete remission now is defined by blast less than 5%, count recovery, making this similar to AML, where the hemoglobin increase is 10 or more. In the old criteria, we used to require 11. There was a study presented at ASH 2 years ago looking at CPX in patients with MDS, 10% myeloblast or more. If you applied the AML criteria, the complete response was 40%. If you applied the MDS criteria, the complete response was 20%. And the only difference was the cutoff of hemoglobin, 10 versus 11. So now this is kind of unified to make it more similar to AML. And then there are categories introduced to recognize the importance of restoring blood counts or effective hematopoiesis. So we have CR equivalent now, whether it is limited count recovery, where either one of the counts, either the platelets above 100 or the neutrophils above 1,000, or what we call CRH, which is also used in AML now, if the platelets are above 50 and the ANC is above 500. The idea is whenever we restore hematopoiesis, patients' blood counts are improving, they are going to drive survival advantage. Something like the marrow CR, where we decrease the myeloblast, but there is no count recovery, does not actually translate to a survival advantage for patients. And the only use of that could be probably as a bridge to transplant if we could reduce the myeloblast and take patients to transplant. And this is just a comparison between the ELN revised AML criteria and the MDS. And again, all the work was really trying to kind of harmonize those and make them more similar, especially as we introduce this category of AML MDS, that patients will be included on trials, that we have similar response criteria on clinical trials. We also introduced some endpoint response criteria, event-free survival and progression-free survival in MDS trials. Now, in the lower risk MDS, most of the time the primary endpoint for trials have been transfusion independence. In the past, the requirement was looking at 8 weeks prior to enrollment. That had been extended now to 16 weeks. And also, what is a helpful or meaningful transfusion independence duration was expanded. So historically, the IWG, if patients went 8 weeks or more without needing blood transfusion, that was considered meaningful, but that had been extended to 16 weeks. So we need to look at blood transfusion 16 weeks before enrollment and 16 weeks after enrollment to consider it as clinically meaningful. And then we also look at patients' baseline, whether they were not transfusion dependent, whether they were having low transfusion burden or more or high transfusion burden in terms of assessing the response. And those criteria were not changed from the 2018 version that was published by Dr. Platzbecker. So in summary, I would say the modern classification of MDS really emphasizes genetically defined disease entities, such as the SF3B1, the deletion 5q, and the P53. The line between MDS and AML remains blurry. As I do more MDS, I try to call more patients MDS. My colleagues that do AML like to call more patients AML. I think the IPSSM is a refined prognostic tool, no doubt, for risk stratification. And it is validated through different subtypes, so you can use this tool across all subtypes of MDS. And I think it's ready to be utilized to decide on timing for allogeneic stem cell transplant. And finally, the new proposed response criteria hopefully will allow better assessment of drug efficacy in clinical trials and real-world practice. With that, I'll stop and look forward for the questions in the Q&A session. Thank you.